Muted.
On the webinar, most likely next week, we will have a link to that recording available for any of your colleagues who may have missed. It will be online, and we will share that with you all, but there will be no CMEs for the recording, only if you attended live today. As I mentioned, some of you may have heard me mention a couple of times already, if you could please make sure you're calling in with the telephone option rather than your computer speakers. That helps us to ensure the audio quality is better with such a large group. There is the call-in information and PIN under audio in the GoToMeeting box. Once you call in, if you could enter that audio PIN, that'll help me by making sure your name shows up in the attendee list. But as a backup, we do need a roll call for CME purposes. So if everybody could please just take a minute to text your full name, first and last name of everybody in your group who's watching the webinar today in the text chat box and hit submit. That will give me a record so that I can do roll call for CME. As we get going in the webinar, we will have everybody muted, but if you have questions, please feel free to type them into the chat box and I will monitor that. The slides from the webinar and for the evaluation will be sent out tomorrow, and we do need you to complete that evaluation and send it. Once you submit it, I will send you the instructions on how to obtain your CMEs or CEs. And finally, we're going to turn it over to Ana Alonso, who is the Office Chief of Chronic Disease at Arizona Department of Health Services, and she is going to give a brief introduction.
Thank you, Tracy. Welcome everyone to the Controlling Hypertension in Adults webinar that my office is sponsoring in collaboration with our wonderful partners, the American Heart Association and the Health Services Advisory Group. This webinar is funded by the CDC 1305 grant, which is also known as State Public Health Actions to Prevent and Control Heart Disease, Obesity, and Associated Risk Factors, and Promote School Health. This 5-year grant supports statewide implementation of cross-cutting approaches to promote health and prevention and control chronic disease and their risk factors. The Arizona Department of Health Services also supports the American Heart Association Million Hearts Initiative and implements various related strategies via the 1305 CDC grant. As you know, heart attacks and stroke disease is the leading cause of death, the third leading cause of death for men and women in this country. And in 2013, heart disease was the second cause of death in Arizona and accounted for over 10,400 deaths. Preventing 1 million heart attacks and strokes by 2017 will require the working commitment to change from all of us. And providers, the provider community plays an integral piece in meeting this goal. Just within the state of Arizona, we have set a goal of reducing death and events related to heart disease and stroke by 10% by 2020. So before we get started, I just wanted to give you all a heads up that we will be hosting another webinar this June where Dr. Ashby Wolf, Chief Medical Officer, Region 9 at the Centers for Medicare and Medicaid Services, will be speaking on meaningful use. We'll be offering CMEs as well for that webinar, so please keep a lookout for information concerning this opportunity. We would love to have you join us in June. So today we've brought you 2 experts in the field of cardiovascular disease to share knowledge and experience in controlling hypertension in adults. And at this time, I would like to introduce our 2 speakers. First, we have Dr. Stephen Chen, and he's the Associate Professor and Chair of Titus Family Department of Clinical Pharmacy, and William A. Heers and Josephine A. Heers Endowed Chair in Community Pharmacy at the University of Southern California. He serves in multiple capacities in the last 26 years and has been serving as a national faculty expert and co-chair emeritus, Patient Safety and Clinical Pharmacy Services Collaborative 4.0 at Health Resources and Services Administration, or HRSA, the U.S. Department of Health and Human Services. He is a member of the advisory board, the Alfred Schweitzer Fellowship Program, Los Angeles MTM Task Force, California Society of Health Systems Pharmacists, and serves on the Pharmacy and Therapeutics Committee, Center for Community Health, Los Angeles. And he is a co-faculty advisor, Medicine and Pharmacy Student Collaboration. And Dr. Alan Go, who will be our second speaker, completed his internal medicine training and a general internal medicine fellowship in clinical research at the University of California in San Francisco before joining the Kaiser Permanente North California Division of Research in 1998. He is currently Chief of Cardiovascular and Metabolic Conditions Research, Director of the Comprehensive Clinical Research Unit, and Regional Medical Director of the Clinical Trials through the Kaiser Permanente North California Division of Research. He is also Associate Professor in the Departments of Epidemiology, Biostatistics, and Medicine at UCSF, and Consulting Professor in the Department of Health Research and Policy at Stanford University. Dr. Go is past chair of the American Heart Association Epidemiology and Prevention Council Statistics and Stroke Statistics Committee, and led the American Heart Association ACC CDC Hypertension Advisory Statement published in 2013. So as you can see, we have two wonderful experts who will share their ideas with you. So with that, we'll turn it over to Dr. Chen, who will be our first speaker.
Okay, bear with us for just a minute. We're just testing the audio. Dr. Chen, can you say hello? Okay.
Hello.
Hello. Now we're going to have you unmute everybody to hear Dr. Chen. So everybody on the line could please use their own phone so that we can minimize background noise and make sure that we can hear Dr. Chen. Thank you.
Thank you. I apologize. I've called in actually multiple times, multiple numbers, and I don't know if I'm calling the wrong one, so I apologize for the technical flaw. Thank you for muting and allowing me to participate in this call. Can I have the next slide, please? For this webinar, we're going to be talking about, I think, many important topics that relate to high blood pressure and hopefully give you some perspective on not only the burden of high blood pressure, but also some very practical tools that can be used to attack this problem. Dr. Go will be speaking about the results and implications of the SPRINT study. Next slide, please. We'll be discussing barriers to achieving blood pressure goals. And as a pharmacist, this is...
Everyone, please mute your phone.
Chicken stomach
Thank you. We're getting a lot of background noise, so we need everybody to mute their phones, please.
I saved my thing. I'm not sure why.
Thank you. Again, I apologize. The other issue that we'll be discussing are some barriers to achieving blood pressure goals. And this is something very near and dear to me as a pharmacist, knowing that the first-line drugs available, if you think about the first 3-4 first-line drugs available for high blood pressure, are generic and very inexpensive. And so it's difficult to understand why it's such a challenge to reach the goals the AHA has set forth. We'll talk about whether population-level blood pressure control is a possibility, and then we'll share the AHA high blood pressure treatment algorithm and principles. Next slide, please. So we have 80 million people with high blood pressure in this country, and that's a staggering number if you think about that fact. The AHA has a very ambitious goal of a improvement in cardiovascular health by 20% by the year 2020, and mortality from cardiovascular stroke by the same year. Looking at the numbers, 1 in 3 Americans have high blood pressure today, and the fact is that for every 10-point drop in systolic blood pressure, we can achieve a 30 to 50% drop in risk of cardiovascular disease and stroke. Next slide, please. It's certainly a very expensive condition to deal with. Over the course of 20 years, roughly 20 years, from 2011 to 2030, we're seeing a 5 to 6-fold increase in the direct and indirect costs associated with high blood pressure. And in that same time period, we're looking at a 13% increase in high blood pressure-related deaths. Next slide, please. So again, getting a little bit more into the numbers now, we're talking about 45.9% of the population, or almost 37 million Americans, who are not at control with their high blood pressure. And again, think about that. I just stated that most medications, the first 4 lines of medication therapy for high blood pressure are generic and inexpensive. So it's a bit shocking to think that we're at that level. Looking down at the bottom of this slide, we only have just over half of patients at high blood pressure goal. 2/3 are currently treated, about 83% are aware, and we have another 17% that still don't know they have high blood pressure. Those are pretty frightening numbers to think about. So what we want to talk about today is a program called Target BP, which was launched in November of 2015 by the American Heart Association. This is an initiative working with the American Medical Association. The goal is to engage as many health systems, clinics, providers, departments of health, health plans, etc., to join together in Target BP and work towards improving rates of blood pressure control. And there's a recognition component to this initiative that we'll talk about a little bit later. So what is Target BP? It's a call to action motivating hospitals, medical practices, practitioners, health service organizations to prioritize high blood pressure control. It's a source for tools and assets for healthcare providers to use in practice, including the algorithm, which we'll talk about later in this program. And again, it's recognition of healthcare providers who attain high levels of blood pressure control, particularly those in the 60, 70, 80, or 90th percentile. We want all healthcare systems to join this initiative and implement the algorithm that we'll share later on. How do you get involved? Well, you sign up. So if you go to this website here, you can sign yourself up, and we hope as people on this call will do so and commit to the effort. And with that, I will hand it off to Dr. Alan Go. Thank you, Dr. Go.
One moment, Dr. Go. We're going to unmute you. Okay, Dr. Go, can you say hello?
Yes, hi. It's a real pleasure to join everyone today, and thank you for taking out the time to talk a bit about blood pressure control, and thank you, Dr. Chen, for that background. Next slide, please. So what I'd like to do is start out by walking us through the SPRINT trial, which made a lot of news in the last half year. This was a pivotal trial called a randomized trial of intensive versus standard blood pressure control. Next slide. So the fundamental question that SPRINT asked was, does more intensive blood pressure control using lower systolic blood pressure targets improve the risk of cardiovascular events and overall survival? And what they did is they enrolled nearly 9,400 adults who were aged 50 years or older who had a systolic blood pressure between 130 to 180. And one of the most...
One moment. Okay, sorry about that, Dr. Go. Go ahead.
Okay, and one of the key things was that unlike some other studies, it did not matter if you're already receiving treatment or not, as long as you entered into the study between the systolic 130 to 180. Next point, please. Now, there were some very important exclusions here, which we can talk about a little later, of how that does apply to our patient populations or doesn't. So they excluded people who had known clinical heart failure or had a reduced LV systolic function, defined as an LVEF less than 35, a history of prior ischemic stroke, diabetes, polycystic kidney disease, or substantial proteinuria, or advanced kidney disease, in this case defined as an estimated glomerular infiltration rate less than 20. And that's really important to think about the generalizability of the findings we see when we think about the patients with high blood pressure in our practices. In order to both increase the event rate and also identify a group that may be more likely to benefit, you also had to have at least one additional cardiovascular risk factor that you see here. And another relevant issue is that they use a Framingham prediction score in which the 10-year predicted risk of a cardiovascular event was at least 15%. And we can talk about that a little later. Now, we do know when we think about lower systolic targets that a lot of us worry about potential adverse side effects. And so I think they smartly plan to look at pre-specified subgroups in terms of older versus younger age, men and women, different racial groups, importantly whether someone had pre-existing chronic kidney disease or not, known cardiovascular disease, as well as what blood pressure they entered into the study. Next slide, please. Okay, so the fundamental goal was to try to get patients who entered in at 130 to 180 either to a target of less than 140 or less than 120. And when we see the results, we'll talk about really what that meant in terms of implementation. The main outcome was actually a composite outcome, which included what you see here in terms of ischemic events, as well as heart failure and death attributed to a cardiovascular cause. In addition, there were a number of other outcomes that you see, including all-cause mortality, and then the combined cardiovascular composite endpoint plus death, and because of the concern about impairment of systolic blood flow, for example, to the kidney, about renal events, either the new development of chronic kidney disease or worse kidney disease. And then there were also some additional safety events that were targeted that we'll talk through. So next slide. So what I did is I just put in here from the paper the baseline table. And it's important just to highlight really that they did a really good job at randomly assigning people. If you just look and eyeball down and compare the different proportions or means between the groups, you'll notice that there are very, very minimal differences. None of these were statistically significant, really. And so I think from a purpose of comparing the results between the two arms, that they're very comparable, at least in the things that they measured. As was just put up on the screen, it is a very important piece that over 90% were already getting antihypertensive therapy at the time they entered the study. There are a few other things I want to highlight. One is that proportionally, they meant to enroll a large number of patients over 75 or older, and you can see here that they did, a fairly large number overall. They were targeting a third to have chronic kidney disease. They didn't exactly make that, but they came reasonably close, about 28%. Reasonably representation of women. And so these were important groups. We know it was a challenge to enroll people in different racial ethnic groups, but they were able to enroll a large fraction of non-Hispanic Black African Americans, and actually not too bad for Hispanics too. So I think that overall I would applaud the investigators for doing this. Now the other last thing I'll point out, because it'll come up in the results, is if you look at near the sort of 3/4 of the way down in distribution of systolic blood pressure, you'll notice that when you break it down into the proportions of the different entering blood pressure, if you remember the range is 130 to 180, 1/3 of the patients were 130 and 132 when they entered into the study in each group. And then you see the breakdown for the remaining 2/3 of patients. So just keep that in mind as we look through the results, because obviously those are people that I think many of us would have said was under pretty darn good control to begin with, but we'll take a look at the results, and it's very interesting. So next slide, please. So how did they do in terms of implementing this systolic blood pressure difference? And as you can see here, they did a really, really good job. So very quickly after entering into the study, you see separation of the two arms, and that it was maintained throughout the follow-up period. As we click to the next, you'll see what the differences are in terms of actual average blood pressure. So you can click to the next. There we go. So at year 1, if you take a look, the mean systolic blood pressures in the group targeted to be less than 140 was 136, and the group targeted to be less than 120 was 121. Keep this in mind. This is actually what we're comparing the results of, even though the target for the intervention group was actually less than 120. So half the patients were less than 121, half were above. But just keep that in mind as we think about it, how it might, again, apply to our patients from the results. Next slide, please. So these are the primary results, both the outcome of composite as well as death from any cause. And as you can see here, the standard treatment curve is in blue, the intensive treatment in gold, and basically the top panel shows that intensive treatment was associated with a 25% relative reduction in the primary composite outcome for cardiovascular events. And for death, you see, in fact, there was a benefit that was very similar in terms of the relative difference, also favoring the intensive arm. Because of these results, actually, the SPRINT trial was ended early after review of the results because they were dramatic and they were actually larger than anticipated. And so the study was able to end earlier except for the follow-up of cognitive function, which is, I believe the data has been finishing up and will be reported likely either at the end of this year or hopefully early next year when we look at that. So all the rest of the outcomes we have as we go to the next slide, but the cognitive impairment will be the one to watch out for as well. So importantly, you see the overall result here. This is a forest plot, and it shows you in different subgroups how the results fared. And if it's on the left of the vertical line, it favors the intensive treatment. That is, again, a systolic blood pressure target less than 120. So as you look down, you'll see that there, in fact, was a favorable association with intensive treatment in each of these pre-specified groups, including those with or without chronic kidney disease, people who were either younger than or older than 75, men and women, patients who are black or non-black, those with or without known cardiovascular disease. And interestingly, no matter where you entered in terms of the study for blood pressure, there was also a benefit. And even though some of these individual estimates crossed that vertical line, just statistically, there really was not a significant overall difference in the two groups or the three groups. And so there was a consistent outcome that was favoring intensive therapy, at least for the primary outcome. But appropriately, we need to look and say, well, what else happened to these patients, and is there any downside? Because so far, if you just look at this, it would say, wow, the intensive therapy is definitely what we should be doing for at least all the patients that met the criteria. The next slide, please. Okay, but there are other outcomes we want to pay attention to. So, 1 second. Okay, so the individual outcomes for the when you look at it, if you can go to the boxes, that would be great. Okay, so basically, when you look at the individual components of the primary outcome, it was favoring the intensive therapy for all but the hospitalized acute coronary syndrome, which is basically unstable angina. And there, that was the only one of all the outcomes which was not favored with intensive treatment. And also, when you look at different composite outcomes for renal disease and the individual ones, it actually overall favored intensive treatment if you started out with chronic kidney disease. Now, what's interesting, though, is that when you look at the subgroup who did not have chronic kidney disease, it found that there was actually a higher chance of having a reduction in your baseline kidney function. And we can talk about what that is, but we do know that things like ACE inhibitors and angiotensin receptor blockers were used as part of the therapeutic regimen for patients in either arm, but particularly the intensive arm. And that may actually be attributing to be one of the causes for what it is. Because if you look at albuminuria, which is a reflection of structural kidney disease, it actually was lower in the group that got intensive treatment. So that will be something, too, that longer term we're going to need to follow. We know that the clinical renal outcomes were underpowered because the follow-up was shorter than expected. Next slide. So the other aspect we worry about is in managing patients with blood pressures. What happens if we drop their blood pressure lower? What other things can happen to them? And as you can see, hypotension, such as hypotension, syncope, and others that we think are directly related to having lower blood pressure, and that was certainly more common with intensive treatment. When you looked at people who had to go to the emergency department as well, that included hypotension as well as syncope, as well as electrolyte abnormalities, which is not surprising. But when you combine them all, there was no overall effect, but for individual ones, there were. And these were exactly what you would have predicted, actually, when you think about what kinds of medications we're using and what are the potential complications of therapy. Next slide. You can keep going. Okay. Okay, so that was really sort of the Reader's Digest version of going through the sprint trial, but I wanted to hit the highlights and then come to what I believe are really the implications of the study. So in my perspective, I really think this is a pivotal randomized trial, particularly given recent guidelines that have been suggesting we should be more lax in terms of our systolic blood pressure target, particularly in older patients. And in this case, the evidence strongly supported a cardiovascular mortality benefit if you target an SBP less than 120. Again, the average achievement was around 121. And these are people who started with a BP of 130 to 180 with the caveat that they didn't have diabetes or heart failure or impaired LV function, no prior stroke, polycystic kidney disease, proteinuria, or advanced kidney disease. So with those caveats, I think the trial provided really important evidence about cardiovascular and survival benefit. We also know that intensive therapy comes at a cost. Those costs are, of course, the cost of the drugs themselves, even though they are cheaper these days as essentially generics were used. But there are certain adverse events that we are wanting to pay attention to, including hypotension, syncope, acute kidney injury are ones we particularly want to pay attention to. But also noted, at least in this selected population, there was no difference in all serious adverse events which required hospitalization or were deemed life-threatening. And that is an important overall message when we think about that in mostly older patients. We do know that there are additional analyses that need to be done. There's still concern in patients, particularly in more advanced kidney disease, of what the optimal blood pressure target is. And there are differences in this trial versus in observational studies about whether an aggressive blood pressure target is really going to be ideal when we think about the net outcome in these patients. The other aspect I alluded to early on is we worry about whether or not reducing systolic blood pressure in particularly older patients who have stiffer vessels may in fact impair cerebral perfusion. And if that's the case, it may not lead to an overt stroke, but maybe it may lead to impaired cognitive function. And so that is a really, really critical piece that we're going to look for. And finally, as I've been mentioning throughout here so far, is how do these results ultimately generalize to groups that were not included? Now, I'm sure you're asking, why weren't these people included? So, number one, when you look at the diabetes question, there was already two major trials, along with a couple smaller trials, suggesting that blood pressure control may not be as effective. They were actually, some of them were ongoing when the sprint was being planned, but there's reasonable evidence that the results may in fact apply quite well to diabetics, and there's an ongoing controversy and discussion about whether we need to replicate sprint again with a really dedicated BP trial in diabetics that is not combined with anything else, as that may be part of the problem with the earlier trials. Can you go back a second, please? The other thing is heart failure. There was another ongoing study in heart failure, but more importantly is because ACE inhibitors and ARBs were going to be part of the regimen, and that if you have impaired LVF, you really couldn't ethically withhold those agents. Prior to stroke, there was another study that was ongoing, published subsequently in the Lancet about blood pressure control, and it wasn't deemed possible in people with very low GFRs to randomize them to very low BPs at the time. So we want to keep that in mind when we think about how this would apply, in fact, to different targets in our own practice, and I think we will hope to see some new guidelines coming out from the ACC and the AHA combined working group sponsored through NHLBI that will help provide some clarity about what we might target in terms of a reasonable goal overall, and also in groups that were or were not included in sprints. Okay, next slide, please. So it brings us to the question that Dr. Chen mentioned, is that when you look nationally, we're not achieving what we want to in terms of quality of care for blood pressure control. So the question is it possible? Can we really do this? And I will answer with a resounding yes, we can. And so I'm going to show you some examples of how you can do it and then some tools. So if you go to the next slide, this is an example from the Veterans Affairs health system, which, as you know, is one of the largest, if not the largest, integrated healthcare system. And as you can see here in these curves, in the y-axis is the percent of patients in the different racial ethnic groups who achieved a blood pressure target of 140/90 or less over time. And as you can see, it's been improving dramatically over a decade. And you can see it has been, fortunately, has been in all groups, although there is still some residual differences among black versus Caucasian or white patients that they're still trying to figure out how to reduce. And then that's a unique thing. You might say, what about veterans and how they apply to our practices? So if you go to the next slide, within Kaiser Permanente in Northern California, we also looked at this and compared our performance versus what was happening in the rest of the state and what was happening in the rest of the country. And what we want to point out here is that how you measure blood pressure and what you use as a metric is really important. I'm sure all of you are aware of the HEDIS measures through the NCQA. It's a quality benchmark which allows us to try to compare apples with apples. So as you can see here in the circles, you'll see for Kaiser Permanente in Northern California back in 2001, we only had about 44%, I believe, under control. Hit the next, hit the page down for me here. You'll see the number, so 44. And over that 8-year period, we were able to increase it to 80%. And I'll walk through what it took to do that and how we're trying to maintain and, in fact, improve on that even further. When we look at the comparison with national benchmarks, again using the same measure, you'll see here that in the nation it was actually higher than Kaiser Permanente in 2001. You can hit the page down, please. So it's 55% in 2001, but only increased to 64% in 2009. So it's a little disappointing that even within health systems at the national level, that we've made only really modest progress that is a little better than what Dr. Chen mentioned for the overall country, but at least for using HEDIS, it is still disappointing that basically less than 2/3 of people with known hypertension, in fact, were under control in 2009. And then because the California might be considered different than the rest of the country, we wanted to compare against statewide data, again using this. And you'll see here between 2006 and 2009, while there was a modest increase, it only went up to 69%. So a little better than the rest of the country, but Kaiser Permanente was able to do substantially better than the rest of the state. And the main message here is that with concerted effort and with systematic efforts, we can achieve very high rates of control. It's actually been demonstrated in Australia. It's also been demonstrated in other health systems that we know about, that are some published, some unpublished, really pushing us, I think, as providers and clinics and health systems, departments of public health, to say we really can. We just have to make sure we can implement systems and tools to do this. And also, as Dr. Chen mentioned, make it a priority from the beginning. So next slide, please. Oh, I do want to mention, too, just more recent data in 2014 is now we've been able to increase within Kaiser Permanente to close to 90% from the most recent numbers. So I think, you know, one of the questions will be what happens after Sprint has an impact on guidelines, but nonetheless, I think it is hard to maintain and get better at this, but really this is just say it is possible. So next slide. So let's talk about the barriers next of why is it that we do struggle in the country to achieve blood pressure control on large scale. Next slide, please. So one of the challenges is that in many ways we've worked on a patient-by-patient, which is important in terms of personalizing care, but we want to encourage people to think about it in terms of their own practices, no matter how big it is. And if you're really representing a health system, to really think about health system-wide. And to do that, we need to understand it is not a single approach. We need to hit blood pressure at multiple levels and to maintain a persistent effort over the long run. We describe a lot of the details that I'll share today in brief in our 2013 paper that came out as an advisory on an effective approach to high blood pressure control. Next slide. So when we think about how we can do this on large scale, again, I want to help us think beyond just the individual patient. So when you look here, it's very deliberately organized in this figure to show you the importance of all the different players to make this happen. Again, if you think at the bottom, the providers and patients, that's often where we're focusing on, just the individual relationship. And it is vital, there's no question. But to get population level control, we need to engage the health system. We need to get our communities activated to recognize this is an important problem. We need to have the families and significant others of patients to also be participating to help us achieve this. And this starts with making sure patients and providers are aware of the problem and, importantly, prioritize it as a health problem that we can solve. I know historically in my own training, there are times people would just say, just give up. It just can't be done. And I think we have to get over that and to let people know it really can be done. Lifestyle modifications definitely form the core. We'll talk about the specific recommendations for that. But fundamentally, the large majority of patients with high blood pressure are going to need to augment their lifestyle changes with medications. This means they need access to care. This is a big challenge. We think that under the Affordable Care Act, it has certainly expanded access to care, but it hasn't made it a complete solution yet. We also want to help to systematize care while also personalizing care, and that's going to be a challenge for providers and also for health systems. While there are some standard protocols, we have to be able to also customize it accordingly. But we're confident that if you look at large population efforts in blood pressure control, a large fraction of patients can in fact be controlled under standard approaches. And then for those who really need to be specialized and customized, that's not a problem. The algorithms that are effective allow for that. And importantly, we have to have patients understand this is not like an episode of acute bronchitis where they take something for 7 to 10 days and they're done. This is a lifelong effort because we want to avoid lifelong complications. That means medication adherence, regular follow-up, and engaging them to be part of the solution and understand that sometimes they're going to have to adjust medicines accordingly. It's not a failure, but that we need to help them do the things they want to do at the right time. And so those are the different stakeholders we have here as we think about how to improve blood pressure control. Next slide, please. So how do we go about this? Again, I'll emphasize throughout that our effort in partnership with the AHA is to provide tools and approaches for providers, communities, patients, and systems to make this happen. So if you can go ahead and show all of the bullets, we'll just walk through these. I think all of us believe blood pressure control is important. You're on the phone. You're taking time out today because you agree it's important. So I don't think we have to start with that argument. But I think one of the challenges is how do we help people do the right thing? Because we know they want to do the right thing, so how do we do that? And protocols help, and they help to get you started from a base, and then we need to go from there to develop the kinds of incentives for patients, providers, and health systems to achieve good blood pressure control. For patients or consumers, increasingly the availability of both devices that are valid to measure blood pressure at home, the ability to engage employers and other community sites to measure BP, not just once, but chronically, and the increasing availability of health-related IT to be able to engage in the discussion between providers and patients are really making it possible to do this now on sort of nationwide scale. Communities have actually not been as engaged, honestly, with blood pressure as they have with many other things, including diabetes and other types of infection control, where they've done a lot better, honestly, than we have in BP. But I do think that there's a lot of partnerships that can be really constructed, established, including, as you see here, the potential for health ambassadors, working with our pharmacists, both commercial and those owned by health systems, to be part of that solution, particularly around adherence and assessment of side effects, the ability to track blood pressure control individually and over communities, and also to work hand in hand with the systems of care to create accountability. You see here what we have in terms of certain kinds of health systems with HEDIS measures, but more importantly, as we'll talk through, being able to systematically identify every single hypertensive patient is really one of the first things we need to be able to do, and then to give feedback and provide positive incentives to keep doing better. Next slide. So how do we go about this? And I'll show you, these are our principles, and then within Kaiser Permanente, I'll show you how they got implemented. And we'll also here, too, at the end of this, we'll see a video about how a practitioner also went about implementing the AHA high blood pressure algorithm too. So as I mentioned, one key thing that we had to struggle with here in Kaiser Permanente was we have to find everyone. So this meant actually using our available electronic data systems and making dedicated resources to identify everyone who has high blood pressure, as well as known or unknown hypertension in that process. So even with people who have a high blood pressure measurement serially, you'd be surprised how often they don't carry a diagnosis of hypertension. So it was a matter of being able to look for both the actual values and the diagnoses within our population. And to give you, for those who know Kaiser Permanente, we care for about 3.9 million people. So we had to work with our IT groups and also with our quality groups to make this a priority. And then from that, it's not a one-time deal. We have to be able to chronically monitor at the overall population level and be able to drill down to individual practices, not pejoratively, but really to say, we're going to help you figure out how to improve blood pressure control and to let them know that it was an institutional priority. We also said we have to have effective diagnosis and treatment guidelines, and we'll show you an example of what we think at least is an evidence-based guideline, and also give you resources online that you can go to tailor one that fits your practice best and is flexible enough to incorporate new data. Another thing that we notice is that it's not surprising to those I'm sure on the phone that patients often get treated but don't get systematically followed up. So how do we do that, and how do we incorporate workflows that allow us to do that? It's really a team game, I think, for medicine these days, and increasingly for blood pressure control it is. So how do we use our physicians best? How do we use our nurses, our other ancillary medical personnel to help us to be able to do all these steps given how busy everyone is right now and the limited resources we're often dealing with. At the patient level, we need to help people be able to be more adherent to their medications and to understand that we are able to respond to concerns about side effects or about other issues they're having. We need to reduce those barriers and make sure we incorporate the medication adherence with lifestyle modification adherence too. They really work better together. There's good studies that, for example, certain medications work much better in a low-salt environment. It's not just about throwing drugs at it. And also, I'm sure that probably every group on the phone has some version of an electronic medical record, and we believe that this begins to form the infrastructure to be able to do a lot of these steps much more efficiently. And I'm excited to hear from our colleagues in Arizona that there'll be future talks about meaningful use and how the EMR can be used as a tool to help us do more large-scale care. Next slide. So how did we actually implement this here, and where I think we can be a model for other health systems considering it? So again, what we did is we looked at our electronic health data, and we said we're going to identify everyone who has elevated blood pressures and or diagnoses of high blood pressure or receiving antihypertensive drugs so that we can try to identify who might have high blood pressure. And then we had to go in and check to see how often we were right and refine those algorithms. So we only identified people who really, really did have high blood pressure and were eligible for being followed and tracked. Next point. So one of the key things was also to have regular feedback. This was not done on a weekly basis. It was actually done about a quarterly basis. And it was really important, we learned, to provide it at a facility level. So in this case, we have 21 medical centers that are within Kaiser Permanente, Northern California, and many thousands of providers. And it was really critical to get this right. So we had to tell people who was in their panel, and both in their individual panel and panels within a facility, and say, here are the control rates, give them a chance to review it, have them look at and see if there's any errors, and then adjust to that and give feedback the next quarter. And I think many of you are familiar with the kind of that. Thirdly, and this turned out to be a really important aspect, was we had to be sure that we had an evidence-based treatment guideline that was updated as new evidence became available. So it wasn't that it was a year old, but as new trials came out that warranted us to change our approach, that we could change it very quickly. And so we developed a physician-led treatment guideline group that would meet just by phone as soon as new studies came out that looked like it might impact treatment, and make a decision collectively if we needed to change it. And if we did, we would do that and disseminate it quickly. And even if we didn't, we would let people know, would this trials come out, or these trials have come out, and we've decided based on the evidence we don't need to change this, or that it only affects sort of the third line or fourth line or something like that. But I think what was really important to all of our providers on the front line was that it was very, very up to date. And that's something that takes time and effort, but that was a key part of, I think, getting buy-in from all of the providers. Next point. And this is something that also it makes a lot of sense, but I think was one of the more powerful pieces, which was for most of the patients who are going to need treatment, they're going to need 2 to 3 drugs, particularly if we end up trying to achieve the kinds of lower targets that the SPRINT trial may imply. And so single-pill combination therapies, which we know can increase adherence because the fewer pills you have to take in a day, the more likely you're going to take them all. That when we combine promotion of those combinations in a single pill formulation, in addition to emphasizing dietary and lifestyle modification, that turned out to be very effective for our patients and much more acceptable, particularly as you can imagine, particularly older patients with high blood pressure have a lot of other problems. And the fifth thing that was a structural decision was to have medical assistance be a key part of ensuring people came in for blood pressure checks. And what I mean by that is that people were on a protocol to be followed up, particularly after they had either an initial blood pressure that was elevated off treatment, where we wanted to make sure to see if it was sustained or if it was due just to an acute illness, or people who had a change in their therapy. Is our medical assistants were empowered to have the follow-up checks be scheduled and to do them, and if they were meeting targets, patients were fine, they were allowed to keep going, but they would have physician backup if there had to be any kind of medication change. And related to that, because it's so costly in general, we wanted to remove any barrier to the patient. So if you came in for a BP check, you didn't have any copay, because we want to say don't use a financial barrier as a reason for you not to get your blood pressure under control. That was very, very deliberate, and I think ultimately a very good cost-effective decision. So this is just an example of how we try to apply and implement that approach in thinking about multifaceted structural and system-level approaches. And so let's move on now to the idea of both the principles and the goals of a high blood pressure treatment algorithm. And we highlight this in the advisory because we know that not every practice and every population is the same. But we do know there are principles that we can apply that will help us have the best type of algorithm that you can implement in your own practices. So as I've been mentioning, it's really critical that we use the best available science. We know that a lot of our best evidence for treatment comes from randomized trials, but also supplemented by rigorous large-scale observational studies. So starting with that and finding sources which are readily available that summarize these data help to get you started. The next item is that we want to make it easy to update all the time. And that way, when new studies come out, you can adapt it quickly. And that, believe it or not, none of us have extra time in the day. So when you have something you can adapt and disseminate quickly, that's obviously key. We also want to make sure that it's pretty clear to patients and to providers what are the steps in this process so that we can implement it. I think when it gets very convoluted, it's very tough. When we try to think of every possible exception, it gets very hard to implement. So that was really an underlying principle, is to try to keep it as simple as we could, and always knowing that we may need to have special cases that we can deal with on an individual level. In engaging patients, we want to make sure that whatever we're saying in terms of provider-driven goals and strategies, we want to make sure patients get it as well, and that we write things that are at their appropriate scientific and language literacy level, and that they know what's coming. I think that's part of the challenge. When people have blood pressure medications adjusted or added, again, at least in my experience, some of them think, I failed, when in fact it's not necessarily failure. It may just be that that's the way that their blood pressure acts. And if they know that if their blood pressure is elevated, that will lead to a change in medications, either increasing dosages or adding or replacing, then it just helps with their overall perspective on this lifelong goal. The other aspect is we have to think about things that affect cost to the patient, to the insurers, to everyone, and then think through how we implement therapeutic strategies. I'd strongly encourage to make this a team effort as opposed to just a physician-patient effort, and really take advantage of the great skills we have across the different medical personnel that are in our different systems. And I think that it really can make it feasible to do a large-scale implementation. I'll again hit on this, that is, electronic health records, I believe, do serve as a great platform and backbone, and ultimately validated clinical decision support tools that allow you at the point of care to get the kind of support for things that we all agree in, and you say, hey, I want to do this, and they make it easy. So what do I mean by that? That means that if you have a protocol in place that could be embedded in a decision support tool that you agree to, that is based on the best evidence, it can recommend to you, hey, this person's dose on X drug should be increased. Is that okay? You click off, and immediately sends off the prescription to the pharmacy, and the patient can go pick it up, as opposed to having to do all those additional steps. That's where I hope we will end up in as a country, hopefully over the next several years. And finally, we want to make sure that this isn't just about robotic medicine. We want to just provide an algorithm that meets these criteria, but we do the treatment within the healthcare provider's best judgment. We understand fully and agree that the provider can customize the therapy appropriately, but again argue that on a population level, the majority of patients, the overwhelming majority, can in fact get under control with the combination of both structured protocols that get customized to the patient. Next slide. So what also is really important as we think this through, one is throughout this, think about how to make it clear and simple, how we combine the use of drugs with lifestyle modification, that we think about how the initial severity of hypertension or the ongoing severity drives treatment. Seems obvious, but that's a really important issue. That we reduce time intervals from titration of medications and reassessment. I think a lot of us, at least historically, have probably been trained under different scenarios of how long we should wait to see if a medication would work or if a change in dose worked. And our argument is to have that be a structured interval and to make sure that it is systematically implemented. Next, we want to try our best to use low-cost first-line therapies that we know have the strongest level of evidence possible. And, of course, that we have to think about their other medical conditions. Do they have chronic kidney disease? Do they have diabetes? Do they have COPD or asthma? Do they have heart failure? And then, obviously, help those influence our choice of medications, and both initially and subsequently. Next slide. So in terms of the recommended elements, I think I've actually highlighted a lot of these before, so I won't spend a lot of time on these, other than to point out is that we want to try to be systematic as well as when we need to engage other groups, including other specialists that can help us when a patient's not responding. And we also need to think through the concept of drug-related adverse events, so that when we're going down, particularly adding more and more medications, we have to be very, very sensitive to both drug-drug interactions as well as drug-related events as we think about what our net overall benefit would be. So I think I'll move on to the next slide because of time, but just to point those out, that we don't, again, think that everyone will make it through the algorithm perfectly, but that we have a way to get through. So I'm going to walk through now in the next several slides what is an approach we think that could be a good model to start with, and then we'll give you a website that shows a whole bunch of other ones that are very similar, but give you really the chance to see how different organizations and institutions have implemented this. Next slide. Okay, so what we want to do is hopefully what you'll see here really does highlight what the principles we just described are, and we tried our best to make sure we were being consistent. So hopefully, number one, this is visually appealing to you, and that is color-coded and gives some very clear directions and doesn't have 30 different arrows going off to the side. That's really was part of this, was let's try to make this straightforward and move down a particular course of therapy. You'll also see on the left side that you can get an interactive version of this at the website there, and as Anna noted, the slides will be distributed, so you'll have these for your local use too. Next slide, please. So when we think about this is treatment by severity. So that's one of the key things, is that we want to think about this for all adults, and again, because of Sprint, people who are in the oldest ages also are not excluded anymore, as some of the recent guidelines may have suggested that we could be more lax. So I think one of the things is just to think about this and know that our structure is based on the blood pressure they come in at, whether or not they're untreated or treated. Next slide. Okay, so this is the top of the algorithm. When you look here, the idea is treat based on their stage and then to recheck. So as you see here on the left in blue, this is someone coming in with systolic 140 to 149 or diastolic 90 to 99, and the treatment options are lifestyle modifications for a short trial, or start off already with a thiazide diuretic. And as you go down, you'll notice it's recheck and review in 3 months. So these are people with what we would consider stage 1 hypertension, and we want to make sure that they've had it measured at least more than once. Usually it's over a couple months to make sure it isn't just a sort of a single high measurement. But the key is don't just let them go off for a year, which can happen. So the key is emphasize lifestyle. Only a short trial, you'll see no longer than 3 months to see if it's had any impact on their blood pressure, and depending on how high they are, consider starting on a thiazide diuretic. And then on the right side, if they're already a systolic of 160 or higher or diastolic greater than 100, we can tell you right now, and we know this, is that they will not avoid medical therapy. And so we don't want to start with just lifestyle because we know that the effect of lifestyle is still modest. It's really important, but it's modest. And so we recommend that you emphasize both lifestyle and initiate therapy. And these are just some options that can be customized based on their other characteristics. And in this case, you'll see we're already emphasizing early follow-up. So that means recheck review in the first 2 to 4 weeks. That's both to see whether or not the medications are having an effect, but also to ensure we ask about side effects and then can modify therapy accordingly. And from that, we can go down this guideline to whether the blood pressure is a goal or not, and then we branch further down. Next slide. So if the BP is a goal, that's great. So that's down the right side. But we want to make sure that we are following up appropriately, and we want to make sure that they are adhering to the meds. Let us know right away if they're having any type of symptoms that might be related to their medications, because I think that's obviously one of the #1 reasons why, along with being asymptomatic, that people will stop their meds. If they're not a goal, then we want to make sure that we look at the dosages and also whether or not they may need an additional agent. And so that's highlighted in the box around further options. But again, you'll notice 2 to 4 weeks, consistent with what we saw earlier on, that when you have to initiate therapy, we want to recheck quickly. And then go again. If the BP is a goal, and then you head to the right and you follow up accordingly on a regular basis. If not, we consider escalating the therapy yet again. But we also at this point have to consider whether or not there might be other causes contributing and whether we should consider engaging a hypertension specialist or other physician help in terms of evaluating other explanations for the high blood pressure. Next slide. So we've been mentioning lifestyle modification this whole time. So what are the 5 sort of key areas for lifestyle modification? Actually 6 here. One, I think, is we often, because of the American Heart Association, we say don't smoke. So it's not listed here, but that would be #1, is we want them to stop smoking and to do everything we can to facilitate that. So take that one off for 1 second. But here we focus on helping them obtain an optimal weight, which is really a combination and an impact of increasing their physical activity and having a heart-healthy dietary eating plan, to have moderate alcohol use, which at least currently is still 1 drink per day or less for women, 2 drinks or less for men, and also to focus on lowering their sodium intake. We know that this is a little controversial on what the actual level should be, but even striving to reduce, particularly the processed foods that contain so much sodium, helps both the medications work better, and in and of itself, particularly if you're salt sensitive, can reduce your blood pressure. So these are really the 5, plus the smoking cessation, that are part of all we're talking about for lifestyle modification. Next slide. And importantly, as we've been talking about, we want to make sure our patients are engaged. So in addition to what we are recommending for providers to know, we want to let you know there are a lot of different resources for patients, and they're readily available, they're free, and we can hand them out to our patients. So one is to make sure they're aware of the importance, and you see just examples here about knowing their numbers, and also what it means to control and reach their BP goals, what it means to, in terms of the individual lifestyle modifications they can work on, and also the importance of early follow-up so that they can get rechecked. These are all things that we want to give to our patients. Again, let them know the plan, and let them know, too, that it is not surprising, if you look at the natural history of blood pressure, that the majority of people will need to be on at least 1 medicine, and a large fraction will have to be on multiple medicines. Again, so they have that in their mind from the beginning. That may be where they end up. It may not, but they won't be surprised, and it won't be deemed a failure. Which, again, I think is so important mentally to frame to our patients, and I think it helps them when we think about the long term. Next slide. This is yet another one. I actually like this. This is one of my favorites, actually. about the 5 simple steps to control your blood pressure. Why do I like this one? The other ones are great too. Is that I do think that the devices at home, you look at number 4, being able to check your blood pressure at home, the devices are getting better. And increasingly they're getting tied to our smartphones. And as we become a more connected society, and as you'll hear about I think a little later, that the ability to transfer information to our providers, that's going to become a reality pretty soon. So I think this is one I like because even if you can't do it easily now all the time, we know it's coming quickly. And it fits really well in the idea that they can take ownership and responsibility to maintaining it. We all know patients that will check their blood pressure every 5 minutes if you gave them a cuff. That's the one downside of all this. And how we actually use the information when people have varying blood pressures at home is another good question. But I do think the more that we have patients, just like those who check their blood glucose, those who check their weight, those are just things that we think for the hypertensive patients that a regular checkup, not every day, but a regular form of checking their BP while on medicines or implementing lifestyle can really help to better understand the patterns of blood pressure. And as many of you know, for people who have different patterns or resistant high blood pressure, we'll often do more complex things like ambulatory blood pressure monitoring to see whether or not we see different kinds of patterns that help us better target treatment. I like this one because it really does try to push awareness. It talks, number 2, about having a therapeutic plan with their providers and their team, emphasizing some lifestyle changes, making sure they get regular monitoring, and to adhere to them. So I do think it captures it well visually and also the key messages for the patient. Next slide. And this comes back now to the practice level, which is how do we try to help out and do this? Well, audit and feedback is really been the cornerstone for improving quality overall. And I think one of the key things is to be as specific as one can. It certainly worked within Kaiser Permanente. Each of the 21 medical centers identified a physician champion. And part of my job is to work with people in this medical center, my medical center, to see how we can better implement a structured protocol for blood pressure control and improve our numbers. And what does that mean to improve our numbers? And so here's some examples in the middle section, which is, wherever we start, we know we can get better. And so from that, we have to have some tangible goals. So, can we achieve a 10% improvement over the next quarter in the number of people who have high blood pressure to be under control? And to give feedback on a regular basis. And I think that's the key. Wherever you start, it doesn't matter. I think it's a matter of being able to continue to improve. And I also think that we celebrate the winners, not winners, but the people who are achieving, better performance. And I think not to criticize others, but really to then share what worked. And that was another way to try to improve morale around this and help people to work together. And of course, analyzing the data is really critical, being able to look across an entire practice and also within practices. Next slide. So as you've heard throughout this, I really do believe it is a team-based solution. And again, making hypertension control a priority. Some folks, for example, who, back in the day of the paper chart, would use stickers that just said every hypertensive patient gets a red sticker, for example. Now you can do that through best practice alerts or others, and you have to just find what works for you. But I think also both assessing the skills that you have on your team in terms of your medical and ancillary personnel, again, getting patients, family members, or other significant others to understand that they're part of the solution, I think really helps. And in fact, we've often seen that when one member of a family has to begin to make lifestyle changes, it works so much better if the whole family agrees to support that person and adopts the same. So even when you impact on one, sometimes you can impact on many in that way. We also know that particularly when we look at medications, et cetera, we have the ability, and I'm sure many of you do, to get advanced information either through email or other kinds of pre-visit tools. And often, pressure control will ask the patient about any new side effects before they come, and we'll know that ahead of time, or if they've had any issues with adherence to lifestyle or meds. And that way we can use the time we have, which is often limited, to focus on those things as well as do our BP checks. And we also partner a lot with our pharmacies on this too, which has helped a tremendous amount. Next slide. The other part is that this is challenging, but what are the best ways to have our providers be kept up to date about what's important in terms of new therapies, How do we train people effectively to use protocols and accurately measure blood pressure? A really key thing in these recent trials is they're using automated and auto-calibrating blood pressure cuffs. I don't know how many practices on the phone use these, but I do think that is going to supplant the manual blood pressures we've been taking for many, many decades to try to get systematic measurements of BP that are not subject to our own biases that can occur when we do manual blood pressures. And it also allows us to transfer blood pressure measurements more easily into the electronic medical record. Next slide. As I promised, here are some other things that you'll have for you in terms of resources here. I'd encourage you strongly to look at these in terms of available toolkits that you see here through the heart.org, algorithms that are both interactive and static that you can print out, and also the article that we published in 2013 that lays all this out in even more detail. And then I'm going to talk next about another initiative. I think it's on the next slide. The Million Hearts Initiative is a really important one. It actually is a collaboration between the American Heart Association, the Center for Medicare and Medicaid Services, and the Center for Disease Control, as well as many other health systems, in order to try to achieve reduction, basically preventing 1 million heart attacks and strokes. And this was a global sharing effort. And this is not just targeted blood pressure. It also refers to implementing evidence-based therapies such as statin therapy, aspirin in the appropriate patients, and other medications in appropriate patients, and overall to reduce the risk of heart attack and stroke. Obviously, these are important discussions that people should have with their individual providers about if they're eligible for and should be taking medicines like statins and aspirin, and of course, what the blood pressure target is. But the Million Hearts Initiative is really a national effort. And if you go to this website, you'll see a lot of available protocols from different systems, including Kaiser Permanente's, the Veteran Affairs system, as well as other healthcare systems that have been successful. And I think one of the things I really like is that you can implement the same principles in many different ways. And what you'll see across these different protocols is that they've been tailored to the unique clinical practice setting, geography, population, but they all really do adhere to the different principles that I've been describing today. And so I think that's one of the really nice things about this. So I strongly encourage you to take a look at it. It also has templates through the AHA and how you can modify and create one for yourself. Next slide. The other aspect is, again, when we think about engaging patients and practices, that not everyone does have systems that are fully in place that allow us to receive and to transmit and have bidirectional conversations to our EMR. And so through the Heart 360, patients can actually enter in and allow tracking of their blood pressure and also communicate with participating practices. So we want to let you know this is an option for you and your patients, where they can register and your practices can register and link people up together and be able to have a record of their blood pressures. And as you can see here, some cool tools we'll show you just very briefly. Next slide. Oh, sorry. If you just go back for one, I think we took that slide out just for time. But what you can see here is that it gives you a lot of different options for things that patients can report to you that link directly to the cardiovascular risk factors. So it isn't just about blood pressure, but because we're focusing today on BP, it'll allow you to track and graph and look at their blood pressures, communicate between practices and the patient, and allow the patient, if they're savvy enough to work on these web-based tools, to also enter in other kinds of information that they might find useful in terms of tracking physical activity, changes in their weight, et cetera, as you see here. So just, again, another tool to try to make it easier for both practices and patients if they wish to use it, and if they don't actually have it available through their EMRs. Next slide. Also, again, resources for you as providers and health systems in particular. You can see here both our recent AHA heart disease and stroke statistics. This is really a great resource just for understanding the problem and the prevalence and burden of different cardiovascular conditions. Even with Sprint that's come out, there still are ongoing discussions about what are the right targets for different subgroups of patients. Also at the bottom, there's a very nice article that tries to argue how we can approach a multifaceted community-based way to improve blood pressure that, again, I think resonates with a lot of the principles I've been trying to describe here. Next slide. and just reemphasizing the Heart 360 as a way to communicate for patients and also with providers, and a couple other resources for you. We again encourage you to visit and contact your AHA representatives too if you have any concern or questions about other things that you can use. Next slide. So with that, I hope we've covered a lot over this period, but I just wanted to, hopefully you found it useful in going through the SPRINT trial results, because I do think it's going to really change the way that we ultimately will treat blood pressure in the next several years, as well as approaches to controlling blood pressure in both an individual and a practice and a population-based level, and just to encourage us all again that it really is possible, and look forward to hearing about different successes as we all approach this. So thank you very much, and I'll turn it over, I think, to Anna about, I think there's going to be a video played. Yep.
Right, thank you so much, Dr. Go and Dr. Chen. Excellent information. Truly appreciate sharing all your knowledge and also the tools that you had mentioned. Our next little video is going to be from Dr. Akavan, who's a physician from Los Angeles, who has implemented the Target BP program. So we're going to just view a short video.
I'm Dr. Akavan. I'm a family physician practicing in Los Angeles, medical director of two clinics, Health and Health and Customer Service in Los Angeles, as I said. And I'm pleased to let you know that they're having implemented the American Heart Association BP program in September. I certainly would recommend this program to other doctors. One is very simple, and then the next time the treatment as well as the patient. From this team effort, both, and it includes patient compliance with medication and more lifestyle modification. They do have some data to look at, so they look at their blood pressure, they can check their weight, they can monitor and see what they eat, how they eat, they can go to classes. So the fact that they're involved is fantastic. Well, most of that, this program, I think, is the accountability piece, where the patient, given the appointment, to come back with regards to the follow-up of the blood pressure at a shorter interval. And that keeps them accountable. They will come. And also, quite frankly, a lot of times we might have patients that use their appointment, which is just or not. But if it's in the medical assistant and they'll come and keep that appointment, that's great. That's just as good a point as it is not. With regards just to the blood pressure measure. So that's a great piece. So if you just leave it up to the patient, they may not come back. I mean, if you want to fill up our schedule, it's just the blood pressure check, that's not going to work. Initially, it may sound like a lot of work, and in fact it is. But the good news is not all the work has to be for the physician. Obviously, the training will see the patient, we make the diagnosis, and we come up with the treatment plan. But the follow-up of it can easily be handled by medical assistants that really haven't communicated well with you. Once we have the diagnosis of high blood pressure, obviously we like to provide exercise, and we check the patient about 3 months. Once they come back in 3 months, and if it's not controlled, we want to make sure if they're actually really doing the diagnosis. And we also want to make sure that we're monitoring their whole blood pressure. These days, not every patient has to have a blood pressure monitoring their home, and quite frankly, not a lot of health centers do go through this, so that could happen. But the good news is a lot of doctors in the area, and we have a lot of them also for the senior patients, the adult patient centers, they will provide them to them at no cost. They can go and get checked. So that's great news. So they can self-monitor. That also helps us as well, as long as there's some sort of sheet, a very simple Excel sheet that they can write down the blood pressure, and when they checked it, according to whatever the administration recommends for them to check it, whether they think they're old, they can bring it right back to you, which is great. Once they bring it back to you, then it doesn't necessarily have to be you that sees the patient. The medical assistant will do the blood pressure, will communicate with you, and as long as there's no changes in the patient's symptoms, they can continue with the program. It makes sense to deduct, if they say they want want the patient to control of their own blood pressure with your guidance, but the outcome is just like if you look at your bank balance one day and it goes down, and you get scared and you want to do something about it. When they constantly monitor their blood pressure and they see it going up, they're more inclined to do something about it, whether they have something or not. One of the things I would like to share with you is regarding our patient. She's a 32-year-old, very pleasant Latina who was pregnant with a history of chronic hypertension, which means she had blood pressure before she was pregnant. And we introduced a program to her and we got her accountability, and she really loved it, and we loved it. Of course, then before the program, we would always check the blood pressure frequently, but now she was also checking. So now she was doing all the changes and implementation in her own lifestyle that she was supposed to do, and she was measuring blood pressure, which was great. I'm not going to bore you with the medical management aspect of it, but what happened was towards the end of the pregnancy, where her blood pressure started to go up, it was great. She was helping us to detect that, and of course, she ended up being induced with her blood pressure, but it was very safe, and it was in complete knowledge of both patient and us, so it was fantastic from that. With regards to the patient cooperation with the flow net, like anything else in life, not all your patients are going to cooperate and they're going to do it. But certainly the patients that like these kind of things will definitely do it. And the other one, we want to educate them about what we want, what's the outcome, and what is the need for this type of blood pressure control in terms of reduction of cardiovascular accidents. Then they'll definitely be more prone to collaborating with you and working. Once again, putting them in the driver's seat makes them more accountable and makes them want to do it more. And of course, as doctors, when we tell them it's beneficial for you, and if you do it, it makes it easier for us to manage it for you, then it's a win-win situation. No brainer.
Okay, thank you. We have 2 minutes left, so we're going to open it up to any questions. And we did have a couple questions come in over the chat line. The first is, are there any differences in treating patient African American and Latino patient populations? Any preferred medication, first line of choice? So let me open the speaker line back up. One moment.
Yeah, so this is Alan Garner, Dr. Chen's online, but I think that number one, importantly from the SPRINT trial, is that from a target perspective, for systolic blood pressure, there was no difference across racial ethnic groups. So I think that's an important point to remember. So the question about whether or not certain agents work better than others has been an ongoing question for actually a couple decades now, is to whether or not, for example, do Black African Americans benefit less from ACE inhibitors, and do they do better with others? I will say is that if you look in how we evaluated this question, is that we do recommend certain approaches. We do think that diuretics as first-line therapy are often some of the most effective, regardless of race, ethnicity. And then when you start thinking about second-line agents, either in combination with diuretics, such as an ACE/ARB or calcium blockers, for example, that you might consider it, but that, at least from my perspective of the evidence, that there isn't a current race-driven medication that one has to use. At least that's my experience and based on my evaluation of the literature, but Dr. Chen may have a different perspective.
Add that probably a common comment I receive is the question of whether African Americans do well with ACE inhibitors or ARBs, being that they're generally a low-run population. But I think Dr. Go said it very well, particularly in combination. That's not an issue at all. So I will completely agree with your recommendation.
Okay, and another question that came in is, when is the best time to take a blood pressure test, morning or evening?
That's another great question. I think one of the things that, I don't know if it meant is at home or not, but I think the key thing is to try to measure at the same time so you can get a regular pattern in place. And we do know that there are variations throughout the entire day. I know that for patients I've taken care of, often I just have them do it in the morning before they've taken their blood pressure medicines, and if they really want to pay attention to it, that we'll have them take it later on in the day. But I think partly because when you first wake up, this is what you get. But on the other hand, they haven't taken their medicines yet. So at times we'll just have them wait for half an hour after they take medicines just to try to not have an untreated value. But I don't think we know specifically that there has to be an optimal time of the day. We do want to make sure they haven't just exercised or just have smoked recently, because we know we're going to get an artificially elevated blood pressure level. But if they're already getting treatment, I guess at the end of the day, recommend that they take their medication, and then usually half an hour to an hour after is when I have them take their blood pressure when they're sitting down, and then we can look at a pattern over time if they're doing it at home.
Great, thank you. I don't see any other questions that have come in, and we are just about out of time. So I wanted to thank everybody for joining the webinar today. We will be sending out an email tomorrow with the link to the video. I apologize for those of you who couldn't hear it too well. We'll also include the slides and a SurveyMonkey link to an evaluation for the webinar. Once you complete that evaluation and it comes back to me with your name and your email address, I will send you the instructions on how to claim your CME or CE for today's webinar. And feel free to contact us with any questions as well. And thank you again, everybody. Have a great afternoon.